Hello and welcome everyone. This narrated PowerPoint presentation on the management of pediatric patients in paediatric anesthesia care is part of your learning resources under the topic. A list of all intended learning outcomes has been provided to you for your review. I would like to ask you to review all these learning outcomes and get in touch with me if there are any areas that you would like to discuss further or you need further clarifications. Please note, in order to achieve these intended learning outcomes, you are required part of your learning activities to undertake independent study by completing those tasks that are highlighted. I would also like to emphasize that this presentation is an introduction into the topic to give you an overview. If your facility provide services for pediatric patient groups, there may be additional requirements part of your competency achievement that are defined by your clinical setting. In the follow-up sections of this narrated PowerPoint presentation, we are going to be looking at perioperative pediatric patients with their specific needs for peri-anesthesia care. We will discuss some major highlights in terms of differences we may encounter with pediatric patients in relation to anatomy and physiology of these patients, how their respiratory and airway might be affected, their thermoregulation and cardiorespiratory system. We would also look at some of the specific needs for equipment, fasting requirement, pain management issues, post-anesthesia recovery room, and maybe complications and considerations, and so forth. To begin with, I'd like to highlight the most significant differences in terms of airway, anatomy and physiology. On the left hand side of the slide we've got a diagram of the adult upper airway, and on the right hand side the pediatric upper airway, and you can see the differences in the proportion of the tongue and the pharynx, the epiglottis being larger and floppier in the pediatric patients, and also the larynx is more anterior and superior, and the narrowest point in the airway in pediatric patient is the cricoid, and trachea is less rigid or less developed due to lack of cartilaginous tissue in it. In comparison to the two airways, the adults will have its narrowest point in trachea, specifically the vocal cords, whereas in newborns it's the cricoid cartilage. So the epiglottis is usually U-shaped, and it's longer and narrower, and it's more flat in the adult anatomy. Those differences in the upper airway highlights significant challenges in terms of clinical scenarios, because any mechanical irritation during airway management, for example, could cause edema and inflammation in pediatric, and with that there's a potential risk for narrowing of the airway. When we think about the infants, they are diaphragmatic breathers. Their ribs in the thorax is more cylindrical, and they are situated horizontally. That would in turn mean that the expansion of thorax will be limited, because a cylindrical chest will not have the ability to expand and move the ribs up and down. So the ventilation of the lungs or during the process of breathing heavily relies on the diaphragm, and the newborns and the infants, they are nasal breathers, or they are breathing through the nose, and that will cause potential challenges in terms of obstruction, especially if there's fluid retained or if there's any infection or inflammation of the upper airway in the nasopharynx. Further anatomical differences could be highlighted due to having smaller nostrils, having a larger tongue, smaller mandible, and a shorter neck. And there's a huge amount of, or in comparison to adults, there's more amounts of lymphoid tissue in the oropharynx and nasopharynx
and laryngopharynx. So all in all, adding up, that would create a narrower airway, which could easily compromise the airway patency in pediatric patients. The observation and constant monitoring of cardiovascular parameters in pediatric patients are very important. Uh, this is because blood loss will not be easily compensated by pediatric patients in comparison to adults because of their limited reserves. Pediatric patients deteriorate really rapidly, 2 or 3 times faster than an adult, whenever there is a cardiovascular compromise or an airway obstruction. This is mainly due to their size and their inability to compensate faster in comparison to adults. This slide highlights to us how we can determine the approximate blood volume in infants. If we determine the infant's weight for each kilogram, about 80 to 85 mL of blood would exist in comparison to female and adults, where they contain a higher weight ratio, they will hence have a higher volume of blood. And infants, even though the ratio of blood per kg or per kilogram is higher in comparison to adults, because their overall weight is lower, hence the overall circulating blood volume will be very less. Hence any fluctuation in blood or blood loss will have severe cardiovascular consequences. In order to achieve hemodynamic stability for the cardiovascular system, any loss should be compensated as soon as possible. Vigilant observation needs to be made for blood loss, and usually with infants, the younger a child is, the less tolerant they would be for blood volume loss, and replacement may be warranted in clinical situations where there's a 10% of loss, and that would roughly equate to about 300 mL of blood volume in an infant. For endotracheal intubation for pediatric patient group, the preferred type of tube is usually the uncuffed tubes. This is because these tubes will allow slight air leak or gas leak whilst it's inserted within the trachea. Once intubation takes place after laryngoscopy, they try to gently apply pressure within the ET tube and then monitor for some leak. If there's no any obvious or observable leak, then they might reinsert another smaller tube to allow that slight escape of gases. This is to ensure that there's no barotrauma to the pediatric lung. There are a few ways that the ET tube could approximately measure for the pediatric patient. Usually the tube size is determined by this formula, dividing age over 4 and adding 4 to it, and in terms of the tube's length in centimeters, the formula is 12 plus the age of child divided by 2. And these are again a guide only. Each child needs to be assessed within the context of their anatomy and physiology. These are an estimation of a possible size. It's highly recommended for any child that hasn't been assessed in terms of just looking at the theatre list and their age. Equipment prepping, it would be ideal to have the correct size calculated and have a size above and a size below, so ideally you will have easy access to any possible change in the tube size. There's a wide range of laryngoscopes available. They may be preferred Miller straight blades or Macintosh curved blades, and the pediatric laryngoscopes are usually lighter and finer. The smaller diameter of the handle would assist the clinician to visualize the airway better. and it's also recommended to have different sizes and different types of blades available. Airway management could easily pose a challenge, and with multiple intubations or with multiple interventions in terms of airway management, we are also increasing the likelihood of edema, which could be counterproductive in its own merit. When we look at the thermoregulation mechanisms in the pediatric patients, especially neonates and infants, they have got a difference in terms of their fat distribution or adipose tissue distribution in their body. The neonates usually have about 5% of their body mass in brown fat, and that's mainly distributed towards the back and the upper half of the spine and around the shoulders. And this type of tissue has an important role in terms of insulation for the neonate and the infant. And when during the processes of hypothermia or environmental exposures to lower temperatures, this fat starts metabolism in order to produce energy, and they're losing this insulation. The other anatomical and physiological factors that can be accounted for putting neonates or infants at risk is the proportion of the head and body where heat loss could take place through the head having the higher proportional surface area, and also the underdeveloped musculature or skeletal muscle system would render them too ineffective for being reluctant to shiver. The underdeveloped nervous system also cannot process thermoregulation effectively, and again the physiological responses and adjustments will not be made timely. So they all together will create higher risk levels for infants and neonates to suffer from temperature changes, and they are more prone to hypothermia. So the aforementioned points in mind, we could say that maintenance of normothermia is absolutely vital for the pediatric patient within the confinements of the peri-op environment. We need to keep in mind that the infants and the neonates, having an already lower oxygen reserve, their compensatory mechanisms being underdeveloped, they will try to increase the cellular metabolism to adjust to the cooler environment, and that would potentially pose a huge challenge for the patient. When we look at the proportion of surface area of the volume in pediatric patients, this will make them prone to losing heat a lot faster and getting warm a lot faster. So if the environmental fluctuation in temperature is faced by the pediatric patient, the first compensatory mechanism would be for them to increase their oxygen consumption so they could increase their metabolism. What may be some of our preventative measures in terms of keeping the pediatric patient normothermic is increasing the room temperature, so that would provide the ambient accommodating temperature for the child, wrapping the head or the parts of the body that's not necessarily required for the procedure, cotton wool blankets, humidifying anesthetics or warming the anesthetic gases if there is a combination of these structures available within the anesthetic machine, continued temperature monitoring within the child, using warm fluids or warm mattresses, and convective air mattresses if we have them available, or blankets. Perioperative assessment is essential like any other situation in peri-anesthesia care. It should include a thorough assessment of all the criteria, and it's demonstrated that the detail and the completeness of the assessment will lead to reduced risks. Parents are an essential component of the assessment process, and when we are looking after a child in that environment, we are actually looking after the whole family. It's very important to gain trust of the parent or parent involved. They may require ongoing education and information provision, because having a child for surgery is quite a daunting and anxiety-inducing experience. Part of getting ready for surgery, children will be required to undertake fasting, and that may be also a huge burden on the physiological status of children. Usually clear fluids are avoided up to 2 hours prior to surgery, and that's demonstrated that they cannot change the pH in the gastric contents. In healthy elective patients, fasting is required for solid food items up to 6 hours, for milk up to 4 hours, and for clear fluids up to 2 hours. Patients who are at a higher risk and they are unwell, and they are coming in for emergency situations, or they may have suffered a head injury, oral intake should be discontinued, and it should be started when clinically it's allowed. Rapid sequence induction is very controversial. It may be applicable in certain situations in older children, but the younger the infants, neonates, and trauma cases, it's contraindicated because of its inefficacy, for example, or the potential for further damage or narrowing of the airway and compromising patency. Pediatric patients will require specifically designed airway devices and monitoring devices, and that list can include items such as face masks. There's a huge variety of them available, some of them scented and colorful, that would attract the attention of the child and promote engagement with the clinicians before anesthesia care is delivered. Specialized laryngoscopes, where they are smaller or maybe narrower in diameter, endotracheal tubes, a variety of blades, laryngeal masks, securing tape, and some of them are pre-cut, pre-manufactured, trouser-shaped tapes where tubes could be secured, stethoscopes, temperature probes, which are smaller, for example, in size, and also intravenous equipment. It's recommended that Luer lock connections be used in terms of IV connections, because children may be uncooperative and combative, especially post-operatively, and then connections could come off easily. Continuing on with the list of our specific equipment, pediatric suctions may be smaller or modified in size. Pediatric anesthetic circuit might have, the tubes might have smaller diameter to adjust for the sizes. Use of humidifiers within the circuit, highly recommended. ECG dots, pulse oximeter probes, and warming devices. Sevoflurane and isoflurane vaporizers. Some machines, most machines are pre-equipped with them. However, these are sevoflurane is one of the ideal inhalational agents that are commonly used in abundance for pediatric patients, and also having access to a pediatric McGill forceps, which is highlighted in the diagram there. Usually induction of anesthesia takes place either via IV routes or gas induction. The intravenous induction, which is more suited for older children, using a local or topical anesthetic such as Emla cream or Angel cream, would highly facilitate cannulation, and hence increases the margin of interaction with the child and reduces anxiety in the parent and the child. Gas induction is very common with younger children, where intravenous is not ideal. The use of scented masks and sevoflurane or isoflurane is common. And things to remember that gas induction may also include phases of induction delirium, where the child could become very agitated. They might thrash their limbs and roll their eyes. Educating the parent about the process is quite essential, and supporting them during this phase, if the parent's present, becomes a responsibility for the peer anesthesia team. Pediatric circuits might be variable. This is just the two examples that you can see in terms of manufacture variability. They might be disposable or reusable, or they might be modified in different shapes. Our recommended text has got a wide range of diagrams on different types of circuits. It is a matter of recognizing the facilities preference or the clinical scenes preferences. The diagram next highlights the AST piece in the top picture, where you have got a reservoir for the oxygen that comes in from a source, and then that would be connected to a mask, and eventually it would be a handheld device used as a positive airway pressure delivery mechanism. However, these machines, these pieces of equipment, they don't have a specific gauge for regulating pressure. So the reservoir, their pressure application need to be based on judicious use of the clinician's assessment and estimation. Some of the anesthesia risks in terms of respiratory events. Children with asthma and hyperactivity in the bronchi could be at a higher risk of airway compromise. So children presenting with pre-existing airway congenital malformations, respiratory tract infections, obstructive sleep apnea, and also critical incidents due to trauma or foreign body, they could potentially pose a significant risk in terms of anesthesia care.